Welcome to the Be Well at Work program, Managing Depression, Absenteeism, and Presenteeism in the Workplace webinar with Dr. Debra Lerner. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Grants Program through the BC government, as well as through donations and memberships to our organization. As I mentioned, my name is Tanya, and I'll be moderating the session and handling the Q&A today. And our speaker today is Dr. Debra Lerner. Dr. Lerner is a senior scientist with the Tufts Medical Center Institute for Clinical Research and Health Policy Studies, and founder and director of the program on Health, Work, and Productivity. She's a professor in the departments of medicine and psychiatry, Tufts University School of Medicine, and the Sackler Graduate School of Biomedical Sciences. Dr. Lerner also serves as the Director of Evaluation and Tracking for Tufts Clinical and Translational Sciences Institute. Dr. Lerner has dedicated her career to improving the health and well-being of working people and enabling them to participate fully and productively in the workplace. Thank you for being with us today, Debra. I will hand it over to you.
Great. Thank you very much, Tanya. Just checking on my sound. Does everything sound okay?
Yes, sounds good.
So welcome, everybody. I'm happy to be here presenting to you today and hope that we can have a lively discussion toward the end. I'm going to be talking about some of the work that we've been doing here on the program at Health, Work, and Productivity at Tufts Medical Center. And so the program faculty include David Adler, who's a psychiatrist, and Bill Rogers, who's a statistician and sort of ACE methodologist, and we've been working together now for several decades, really focusing on workplace health. That is really our major interest. We look very extensively at workplace health and productivity improvement issues, and I'm going to be talking about that somewhat today. We are very interested in a variety of employment outcomes and labor market participation of people who develop illnesses and injuries sometime during working age. We are interested in the methodology of self-report and survey research, and we use that very extensively in all of our projects, including projects in the workplace. We've been focusing really now for about 10 years on depression and mental health treatments. And that reflects partly the pervasiveness of the problem, its impact on work, and also some promising new approaches to helping working people who develop mental health problems. And finally, we do data collection projects related to information technology and information systems, particularly how to get data in the workplace from people that they feel is private, secure, and also is reflecting their perspectives on health and work. So we do a variety of things, and I'll be talking about some of those things today. So the learning objectives include defining and measuring presenteeism, and I'll come back to that very shortly. Why we think presenteeism is important to both employees and their employers. A rationale for improving the functional outcomes of employees with depression. And you'll hear this term functional outcomes many times. That's really our emphasis here, helping people to do the things they want and need to do in life, including working for as long as they so choose or as long as they feel able to work. And finally, we're going to talk about the health and economic benefits of a new program that we've been developing called the Be Well at Work program, and it is a functional improvement intervention. So with that, I'll just start with a little bit of background. This is data from the U.S. Medical Expenditure Panel Survey from 2004. It's changed only a little bit since then. But really what we, what really motivated us to really start looking more at what was happening in the workplace was the whole idea that so many people were developing chronic illnesses, and part of that goes with the aging of the population. Part of that goes with the successes we've had with some acute forms of illness. And what we see is an ever-increasing pattern of activity limitation. And so for people who are roughly working age, we can define that anywhere from 18 and above, 16 and above. There's all different ways to define working age. But we see that for many people, work is their selected primary activity. And many of the people who have chronic illnesses, millions of people, also have activity limitations. Some people who have activity limitations don't yet have a chronic illness, but this is a huge and growing problem. And when we thought about what was being done in the workplace to really help chronically ill adults to address their problems at work, we were coming up really short. We weren't really finding good solutions, and that's what really propelled us to do a lot of the work that we're doing today. Another thing that really propelled us was looking specifically about what was happening in the medical care system. And I'm going to say that, couch my comments in terms of the fact that these are data from the United States. And so I know that many of you are in Canada, so some of that will apply to North America more broadly, some of it may not. But we did a study back in 1995, and this was a nationally representative household sample of adults with an oversample of people 65 and above. And we were asking them at the time, when they go to visit their physicians, does your physician ask if your physical health limits your ability to perform physical activities, take part in daily responsibilities, perform social activities, and the extent to which your physicians ask about your providers, ask about emotional health problems, how they're limiting you in your life, both in terms of your activities of daily living and social activities. And if you look at the last row there, the rarely or never, what you see is an almost 2,500 Americans that we see a very large number who report that their physicians just don't ask them about these topics. And so I can safely say, as a person who has worked in academic medical centers almost her entire career, that this hasn't changed very much. And in fact, there's probably pressure pushing most primary care physicians away from asking because of time limits and other things that have just sort of risen to the top of consideration more so than activity limitations. Now, this isn't necessarily true of all the subspecialties, but it certainly represents sort of the broad picture of what's going on in medical care. So what does that mean is that when you go to the doctor, even if you're sick, you're highly unlikely to be asked about the extent to which this is affecting you at home, at work, and other activities. So that led us to think about, how are we going to sort of get a grasp of the extent to which health problems are affecting people in the workplace. So we had some data very early on, the extent to which people with chronic health problems were able to work. There were activity limitation surveys done at the national level. Although they're very global, they're not giving you very specific information. We also had employment status measures, but we really didn't have a picture of sort of what was going on inside of the workplace, and also really didn't understand how different health problems or combinations of health problems or treatments for that matter were really affecting people and their ability to work. And so we developed a questionnaire, which I'm going to be talking about, called the Work Limitations Questionnaire, and it's been available since roughly the year 2000. And it was developed as a measure of functional health in the workplace, and because of its widespread use, it's become known as the presenteeism measure, and that's a term that actually a lot of employers in the States use, and it really is describing something very specific. So presenteeism is kind of a goofy word, and it refers to a state of compromised ability to perform in one's job role that is the result of health problems and or treatment. It occurs when the person is not absent from work. We know that presenteeism, in other words, difficulties functioning at work, that's the term that I'll use a lot to describe presenteeism. Presenteeism precedes or follows a period of absence very often. So in other words, people start to have difficulty performing their jobs because of their health problems, and they may hang in there for a while, then they'll take some time off. They may come back to work before they're fully ready to return to work. So presenteeism and absenteeism are very intertwined. We also know from many studies that presenteeism is both predictive of future events and it's predicted by a variety of other events and experiences. So it's related to absences, it's related to utilization, it's related to disability claims, return to work, a whole bunch of things that we've looked at. So it's actually quite a sensitive and important indicator. But more broadly speaking, why we care about presenteeism is really for two reasons. One is that it tells us something about what's going on economically in the labor market and in nations. It is a barometer of diminished productivity due to health problems. It's also important because it's telling us something about population health, and what it's specifically telling us is that people are having difficulty due to health problems functioning in important social roles and social contexts, in this case, the workplace. So this is very important information, I think, from an economic standpoint, from a health standpoint, and that we haven't, necessarily used it to the best of our ability, but increasingly we are seeing the measurement of presenteeism fairly widespread through the United States. So one of the challenges has been, how do you know presenteeism when you see it, and how do you measure it? And so just to give you a little bit of background on sort of our survey research emphasis here is that, unlike height or weight, presenteeism doesn't have a physical reality. We can't really touch it. We can't even really observe it very well all the time. And as someone who's been studying this and measuring it, most of her career, I can look at people in the workplace. I may even know that they're sick, but I can't necessarily tell that some of their performance issues at that moment are due to a health problem. So it's not something that's necessarily readily observable, as you can see by, my two examples off to the side there. We don't really know what's going on, and when people are having a performance problem, we can't always tell that. And if they are having a performance problem, we can't necessarily tell that it's due to health issues as opposed to some other issues. So one of the other important dimensions of presenteeism, or attributes, if you will, is that it's not entirely a characteristic of the person. In other words, it's not due to the person's characteristics alone. It's obviously a relational thing. It occurs when a person is exposed to a task, a challenge, a context. So it happens when we're trying to do work. And it's also experiential. So in other words, it's not an objective thing in the sense that, yes, we can do objective measurements of some aspects of presenteeism, but really it's the person experiencing the difficulty, the limitation in performing their work. So those are really important characteristics in trying to develop a valid measure of the concept and a reliable measure. So we really decided very early on that the best way to measure this concept of, functional difficulty at work or presenteeism was through indirect assessment relying on self-report. And so we needed to create a test that relies on human response. And there were many, many considerations, and it took many years actually to develop the questionnaire and to make sure that it works properly. It actually works like a lab test. It's extremely sensitive. And the four key challenges is we have to be able to ask employees in a way that isn't offensive to them, doesn't create any alarms. So we want to be able to obtain accurate reports directly from employees about their compromised work activity. We want to be able to identify the component that is health-related and not due to other issues. We want to be able to take those reports of health-related functional limitation and convert it into a productivity loss metric. And the reason we want to do that is that it's important to monetize, to get the attention of employers and some policy people, and ultimately to be able to translate the data from these measures into money. What is it really costing us here? So those are all really important issues for return on investment, calculations, value on investment, and so on. So as I mentioned, in around 2000, we released the Work Limitations Questionnaire, or WLQ. The WLQ has two major components. One is measuring presenteeism, and the other one is measuring time loss due to health problems, or absenteeism. And an interesting sidebar is that when we started this work, employers still did a pretty good job of measuring absenteeism due to health problems, or at least they were trying to do that. And many of them have given up, and so they don't really, some of them don't collect absence data. They collect it only after a certain point, or they don't know what the reason is people are absent. They give people these paid time off banks and so on. So what's happened over the years is there's become more of a need for a self-report measure of absence due to health problems. And so we've been working on these measurements and making sure that they're performing well and accurately. Currently, after almost 15, 16 years that the WLQ has been in use, it's very widely used these days. And just to give you an idea of where it's being used, it's included in many health risk assessment tools that employees will take once a year or multiple times a year. And so some of the vendors, the very large vendors that have these health assessment tools, some of them are health promotion programs, some of them are insurance companies, some of them are providers of services, health promotion services. All these kinds of groups often have a measurement tool to go along with it as a way of figuring out where people in the workplace may need services. and also as a way to evaluate the services that are being provided. So the WLQ is embedded in many, many of these tools. So currently, we don't actually even know the number. Millions of U.S. workers take the WLQ at least annually. Employers use it on their own. We work with several large employers that use the WLQ as part of a larger program of employee health and safety promotion in the workplace. It's also used by the pharmaceutical industry as an outcome measure in clinical trials, and it's very widely used in academic research. There are many master's theses and dissertations that use the WLQ, and so this is all very nice, and it's provided us with some really interesting data and understanding of the tool. And to give you an idea of the types of data that we collect with the WLQ, there's really 3 levels. It comes in a 25-question version and an 8-question version, and we use both. The health assessment tools generally use the short version, and you can get all of the scores either through the longer version or the shorter version. If you're trying to get a very accurate measure, you might want to use the 25 items. So for example, if you're comparing treatment A to treatment B, evaluating a program, you might want to use a longer one, but it's not necessary for sort of population health assessment. So all the questions ask about a person's ability to perform a specific job task. Those tasks roll up into 4 scales that measure work limitations in the past 2 weeks and time management at work, performing physical tasks, performing mental and interpersonal tasks, performing output tasks. And output tasks have to do with the quantity and quality of work, and I'll show you some examples of some of the other items. And you get scores on the scale level or job domain level that range from 0 to 100%, and that's the percent of time job performance was limited due to health problems. We also have a validated algorithm that translates those scores into an estimated productivity loss, and the summary score of productivity loss is actually the estimated difference between the group that you're measuring and a healthy benchmark population. So if it's a 5% productivity loss, it's 5% difference between the measured group and the benchmark group. So it provides 3 types of information. All of the questions that are in the WLQ were selected for performance, psychometric performance. They're reliable and valid. They also represent very common tasks that people do on a wide variety of jobs and a wide variety of work situations. And they're extremely sensitive to physical and mental health problems and predictive of productivity. So all of those things are sort of wrapped into those measures. You'll notice here this is one of the full scales. It's called time management. And so if you had the whole WLQ, you would have 4 different scales. And so you can see it's quite easy to read. It says in the past 2 weeks, how much of the time did your physical health or emotional problems make it difficult for you to do the following? And it asks things like work the required number of hours, do you work without stopping to take breaks or rests, and the scale ranges from all the time to none of the time. And if it doesn't apply to your job, you can check that box as well. So it's most people can answer every question. These are very familiar things that are part of the job, and you'll notice we never really use the words work performance or productivity. It looks like an activities of daily living scale, and that was done on purpose so employees would feel comfortable in thinking about their health and how their health was compromising their ability to perform these sort of very basic tasks of work life. In the 8-item version, we have the 4 scales represented, but we only have 2 questions from each scale. And as I said, you can get both the individual item or question scores. You could get the 4 scale scores ranging from 0 to 100%, and you can still get the productivity loss estimate as well out of it. So for those of you who are interested in using the WLQ, I have an email address at the end, and you can feel free. It is licensed, and so you will need permission, but we're happy to work with you to make it available. So to give you a little bit of an idea, the productivity loss and cost estimate is something that we often present to employers, and we purposely made it really conservative so we don't overstate the case of the extent to which people are sort of having performance problems and losing productivity due to health. And you know, we are estimating. We can't get that for everybody, and so we try to use it as a summary score that's as conservative as possible. So we know that it's actually an underestimate of the productivity loss associated with many health problems. but it has been validated, and it does provide some way to monetize the result. I'd like to show you a couple of examples before I then start to talk about depression, but this is sort of the beginning of talking about the importance of mental health problems and presenteeism. This is one way that data may be displayed from the WLQ. These are data from a health risk assessment administered to about 3.5 million workers. And so in this particular case, we just assumed a $50,000 per year salary. And what we do is multiply the average productivity loss associated with each one of these health problems by its prevalence, the prevalence of each problem in this population, and apply it to $50,000 a year. So with the number in parentheses is showing you the average cost per employee, healthy or sick in a company. So depression is number one. So what that means there is 37% of the total presenteeism cost across this population was associated with depression. And this is controlling for all other health problems and so on. And you can see low back pain, obesity, some of the other things there. Now, each one of these kinds of slides that I present is always limited by the types of health problems that are measured. So, you know, there may be some unmeasured health problems that are not here. We're only showing the ones that were measured in this particular circumstance. But this is really, you know, telling us that depression is a huge issue in the workplace. Now, we have other data that, for example, comes from health assessments that measure psychological distress, or psychological stress, it's often called. And if you had that, that would take up another big hunk of the pie, by the way. So, you know, it really depends on what you're showing here. But it's important to know the sort of relative importance in terms of presenteeism of some of these problems. And interestingly, you can get problems like high cholesterol or hypertension, which are asymptomatic problems, and they can still be making it difficult for people to work. You know, why is that? Maybe it has to do with other undiagnosed problems, aches and pains, and so on. But you know, we really don't know, except that people are generally in poorer health. So we have been presenting data like that for years to employers, saying, you know, this is, you know, you have people at work who are really trying to hang in there. They're trying to do their best. They have health problems. And, you know, we want to find ways to allow them to work as comfortably and as effectively and productively as possible for long periods of time. Because as you know, the labor market is increasingly going to need people to stay in it, working longer and being productive. And so we want to make sure that the jobs people have fit them well and that people fit well for the jobs. And so that kind of adaptation process isn't necessarily going to happen naturally, but people are going to need some kind of support and advice and guidance about how to make that all work. The employees will need that, the employers will need that, the policymakers and the providers. So the Be Well at Work program was created to really answer the questions that employers kept asking us when we'd show them these data on depression and presenteeism and also absenteeism, and they'd say, well, what do you want us to do about it? You know, what should we be investing in? Should we just be paying for better medical care? And, you know, the answer is that, yes, you need to be paying for excellent medical care if possible, or somebody needs to be paying for that. And so people, you know, want to get the best medical care they can, but we also know from a large literature on depression that most people don't get excellent medical care, and even if they do get excellent medical care, they may have functional problems for years to come, even when their symptoms get better. So that's really important because it's telling us that there's a gap that needs to be filled in services. So the Be Well at Work program was designed explicitly to address problems of presenteeism, absenteeism, work disability for people who are currently working and have depression. And so I'm going to be talking a little bit about some of our research today. And so we are trying to respond initially to employer interest in reducing the human and economic burden of depression. And that's how we sold the program in order to get funding. But I want to make it perfectly clear that our major interest is in helping employees to do what they need to do and want to do in life. And so that's really important to us. And we were very lucky. We've had several research grants that have allowed us to develop the program and test it sequentially, starting with the first study, a small study in Lockheed Martin Aeronautics, then in state government in Maine, and then our last study was 24 companies. That was a randomized controlled trial comparing Be Well at Work to usual care, and I'll show you some of the information on that. I'll start briefly with some general background. So these data are from, again, national surveys, and the point that these data make is that, depression is highly prevalent. It affects all age groups. It affects men and women and people of different ethnic and racial groups. So it's an important problem across the board. In some companies, you see slightly higher rates, but typically what we see in any company, any day of the week, is about 7% of employees will have depression, and by depression, I'm referring specifically to major depressive disorder, which is a more acute manifestation of symptoms lasting 2 weeks or longer, and then persistent depressive disorder, which is a more chronic form. When we started doing our research, we looked at dysthymia, which was more of a chronic low-level form of depression with symptoms lasting 2 years or longer. It's been since redefined in the DSM-5 and includes some other areas. So some of the data I will be presenting today is on major depressive disorder and dysthymia. It does not include bipolar disorder. This is a very important slide that comes out of the national surveys in the U.S., and this particular slide is pointing out activity limitations due to depression overall in the U.S. population and then by gender. And so what you can see is the mild bar means mild depressive symptoms. The moderate to severe bar is moderate to severe depression symptoms. And what you see is that as symptoms increase in their intensity, the amount of difficulty performing activities of daily living increases. So there's a direct relationship between symptom levels, symptom severity, and activity limitations, including difficulty functioning at work. So again, these are very global measures of difficulty functioning. It's sort of asking, are you limited in your ability to perform activities at work, at school, at home? So they're not getting into the granular level that the WLQ will get into. So we've been studying depression for many years now, and we have the opportunity to talk with people about what kinds of problems they have at work. And so we talk to hundreds of employees who have depression, and it's really hard to sort of narrow it down to what the problems are that they're experiencing. So when I started doing this, I used to think that they couldn't concentrate, they were easily distracted, and there are people that have those problems. But what I've learned is that depression is extremely heterogeneous, and it really depends a lot on the person, the work situation, and so on. So we see lots of people who are just overwhelmed by the workload, and as many of you know, what's happening now in the workplace is people feel like they're doing more with less, and so it affects people with depression as well very, very seriously. We see one thing, which is difficulty adapting to new or changing circumstances in work, and that can be a real problem. People need to be nimble and flexible these days, and when you're depressed, it's awfully hard to do that. Problem solving and decision-making skills sometimes are diminished. Organizational skills could be diminished. We see lots of interpersonal problems. Even people who don't normally have interpersonal problems, when they become depressed, they can feel isolated, disconnected, often feel unfairly treated, feel like nobody's interested in them, nobody values their work, nobody wants to talk to them. Even people who are very senior and are very widely respected, you can get people really feeling terrible about themselves or feeling that others are just not interested in them anymore. And it's tough. And people forget some of the things they already know, like how to talk to a manager, how to talk to a coworker, what's business appropriate behavior. Some of that sort of goes out the window. And of course, low motivation and disinterest is a cardinal symptom of depression. So these can be present in 1 or 2 or 10. There's all kinds of things that are going on. So that makes it all the more difficult to have a one-size-fits-all intervention program, and it tells us that we shouldn't have that type of program. So Be Well at Work is different for a number of reasons. It's employee-centered care. It's really about the employee's functioning and what we can do to help that employee do better in the workplace and to feel better. So we address the medical, psychological, and work factors that are influencing outcome. We do try to customize care to the employee's preferences and needs, and we try to coordinate it with whatever care that employee is able to get in primary care or behavioral health care. So we're not working in isolation. We do try to work with the providers to make sure that that employee is activated to get the best possible medical care that they can. This program is delivered over the web and telephone, and so it has been designed to not be invasive, to take place at the employee's convenience, and so we start with a web-based, privacy-protected health screening. We have a website. We advertise in the workplace, so we work with employers or EAPs or behavioral health to let people know that we're going to be doing these screenings, and I'll be happy to talk more about how we do that and what kinds of ads we put out. But we leave it open for a period of time, and we invite people to come in and, for example, do their annual mental health checkup. And they get immediate personalized results and recommendations. So it looks a lot like the kind of lab test or lab result you might get from the doctor or from a health assessment tool. So for the first time, people receive results on their mental health, telling them whether or not they have symptoms that are consistent with depression and whether they're having difficulty functioning in a way that is really off target compared to national norms or other people in the pool in their particular workplace. Then if they are qualified for the program, and the qualified people are people who have depression based on our assessment and are scoring relatively moderate or highly on the work limitations questionnaire. I'll come back to that in a second, excuse me. They get 8 biweekly sessions over a 4-month period, 50 minutes per session with a dedicated counselor. Most of our counselors are EAP experienced, master's level clinicians who become trained. We train them and supervise them in the Be Well at Work methods. There's an electronic care record, so we're able to go in and look at the care that's delivered, and it's very structured, so the care delivery is following a protocol, and it generates a variety of analytic and reporting tools. The people who qualify for our program, as I said, have work limitations and depression. So if you have major depressive disorder, 95% of those people will have work limitations at a moderate to severe level. So they're already having a lot of problems functioning at work. Many of those people are unaware that their functional level is actually much higher than you would see nationally and much higher than you would see in typically in work situations. So for many people, it's the first time that they can see how really limited they are and getting, you know, a really good data on that helps them to make a decision about care. So it can be highly motivating. For people who have persistent depressive disorder, dysthymia, it's about 75% will have moderate to severe work limitations. So these things go hand in hand, and unfortunately, as I said, very little in medical care is really focusing on what to do about that. The Be Well at Work program has 3 components, and the counselors set an agenda at each of these 8 sessions and try to cover these components. They will rebalance these components depending on what the needs of the employee are over the course of the 4-month period. So we do try to start care coordination, which is basic psychoeducation, talking to people about what the treatment options are these days in medical care for depression. And, you know, a lot of it, but I would say 50 to 60% of the people who come into our programs have chronic depression. So many of them start when they're teenagers, and now they're, you know, at some other point in their lives, and they may be on treatment currently. A whole bunch of them are taking antidepressants, and they're just qualified for a study that tells us they're depressed and work limited, so it's obviously not working. Other people have just said, you know, I took an antidepressant a long time ago, I don't want to take one again. So we don't make anyone, it's not a requirement, but we do try to talk to people about what the current treatment options are and try to activate people in a way so they will get care and talk to their providers about what the options are and what might be best for them. But like disability management programs, we try to do 3-way communication to get the employee, the counselor, and the provider on the same page. So the clinical goal of the Be Well at Work program is to get people functioning effectively at work, and secondarily to help their depression symptoms. So we want people to feel good about their work, to do better at work. And so what we explain to people is that the provider is an important part of this, and we try to get permission to send every 4 weeks an update of the WLQ and depression PHQ-9 scores to their provider, and 99% of the employees give us permission to do that, which is great. So they're not hung up about that, and the providers look at the data for the first time and can see not only how symptomatic people are, but how well they're able to function at work. So this is really important an important change in how care is delivered these days. We also know that, some employees will say, well, and we get this question a lot, well, do employees mind that you only want to talk about work? And we don't only want to talk about work, but we explain to people that work is a core component of people's lives, and the skills that they learn at work about functioning actually translate very well at home and very well to their social lives. And so activating people and getting people going again is really important to help people feel better again, and the strategies that they learn will be helpful elsewhere. So that's our kind of mantra that we use. We also do CBT strategies. We have a workbook that's based on one that was created at Group Health. It's called Creating a Balance, and we've made all of the homework assignments in there about work. So for those of you who aren't so familiar with CBT strategies, it's really self-care strategies that help people to learn how to identify what we would call sort of counterproductive thoughts, feelings, and actions that get in the way of working effectively, and then strategies for sort of diagnosing them and then changing them. So many people with depression feel victimized by their thoughts and feelings or their reactions to things, and for the first time they learn, well, you can actually learn strategies for gaining some control over that, and that's what CBT really helps people with, and it's lots of evidence showing that it's an effective short-term strategy. The last thing we do, we call work coaching or work modification, and here we're doing a very in-depth assessment through the employee, not at the workplace, about what their work demands are. We ask about control at the workplace, support at the workplace, what is really important to getting their work done, what are their work routines, what are the environmental conditions, and then we try to make small changes. We give them homework to go practice at the work, designed to modify their routines or their environmental situation, so they can make their work done more effectively, more easily, less, in a less sort of difficult manner. And many of the people we get will need compensatory strategies. So, for example, they might be having memory problems, or they might be so disorganized that they can't get organized and they're overwhelmed with work. And so we will teach them strategies to sort of fill in where they're going to have longer-term limitations, and that's what that piece is about. And I will just say that the EAP counselors that we have worked with, who come from excellent EAPs, have really sort of lost their ability to do workplace assessment and intervention, and some of that comes from being centralized in call centers, and some of it comes from sort of, making more narrow definitions of what EAPs can do these days. So, it's kind of reinvigorating some of what originally started with behavioral health and EAPs, which is kind of a fun thing for us to do. I'll just say a little bit about our information system. It's designed to support engagement of the program and people in the program through the website. It's designed to support fidelity to the protocol of care delivery and for us to manage and supervise it, and it kicks out reports on a regular basis. So this is something that you just need to do these days in order to have a care system that is really portable and can be done anywhere. So our particular program really could be attached to the workplace, it could be attached to behavioral health, it could be taking place in a hospital. You could set up kiosks anywhere really to get people online or give people a URL. So it's really designed to be a program that anybody can use and can be available much more easily than, let's say, going to a physician's office. So I'll sort of move to the close of my presentation by talking about the last study that we finished, which was a national randomized trial involving multiple employers. It was funded by the National Institute on Aging of the National Institutes of Health, and it took place 2010 to 2013. The study results are published in Psychiatric Services. I think it was 2015 or 2014. I apologize for not knowing the exact date. In that particular randomized trial, we enrolled people who were 45 years of age and older because we were interested in people who are sort of midlife and beyond. Our previous studies were people 18 and older. And we partnered with the Optum EAP and trained their management counselors to understand the Be Well at Work program, and so they worked for us in this particular study. And we were looking at really whether, compared to usual care, the Be Well at Work program was more effective for improving functioning at work and work productivity, and also for reducing depression symptom severity. We were also interested in the benefit to cost ratio. So usual care in this particular project really consisted of anything that the employee wanted to use, and we encourage everybody to get care, to at least visit their provider at once and more if possible. And that was true of both people in Be Well at Work and people in usual care. So we really did try to get people into care. Almost everybody in this particular RCT, they were all working. They all had pretty good insurance. They had access in many cases to some type of primary care. Not everybody had great access to mental health services, but the point was to let people do what they normally do and see whether or not Be Well at Work could achieve a better outcome and got people to stick with it. And so the kind of bottom line here is that after the trial, we were able to show that Be Well at Work is superior to usual care in restoring work performance and productivity among these employees with depression, which was the same result we found in our 2 prior studies. But this was a much larger, more heterogeneous population in all kinds of jobs and workplaces. Interestingly, this is a very unexpected finding and wasn't sort of, as I said, the main clinical goal of what we were doing, but we found that, at least in the short term, the Be Well at Work program improved depression symptom severity levels to the same levels or better that you would obtain with antidepressants. Now, that's not to say that people shouldn't be on antidepressants or be getting psychotherapy, high-quality psychotherapy. It's just in the 4-month period, the people who were in the program did very, very well in terms of their symptom severity scores. And I'll be able to show you some of that data. So here's our consort diagram. So we screened as many people as we could, regardless of whether or not they thought they had depression. So we screened, we did roughly 18,000 screenings. Most of the people do not meet criteria for depression. You can see that off to the side in the blue box. Other people were ruled out of the clinical trial. Some of them had poor physical health, and so we didn't take them. And they had to be really quite sick in order not to come in. For those of you who know the SF-12, they had to have a score of 30 or below, which is quite sick. We excluded people with mania or psychosis, chronic and current substance abuse, people who are not employed and not working in the U.S., and we had some refusals who were eligible and didn't participate. So we randomized 431 people. Our dropout rate was ultimately about 10 or 11%. It was pretty good. And we had no differences at baseline between the usual care group and the Be Well at Work group, and we tested it all sorts of ways. So this is sort of the result that we, I'll show you 3 slides on results. So this is the WLQ score here, and I'm showing you the summary at work productivity loss score. So the first 2 bars, the blue bar and the orange bar, are the usual care group. So this is a very typical result. We see people coming in with depression at losing about an average of 10% productivity. And in usual care, it goes down after 4 months to about 9%, which is a statistically significant drop. But it, from an employer standpoint, it's sort of a 1-point difference on average, and it's not very good. I mean, so when you look at the Be Well at Work program, you see that obviously a much larger, more statistically significant change, and we think an important change for the workplace, both for employees and for employers. So it goes from 10.2% productivity loss in the past 2 weeks, which is quite a bit of productivity loss. It means roughly losing a day a week while you're at work, to about 5.7%. So that's a really excellent sort of change that we were looking for. Now this is productivity loss due to absences, and this is measuring absences in the past 2 weeks at baseline and 4 months later, and we look at the difference scores. So how we get the percentage of productivity loss is the percentage of hours missed over a 2-week period to the percentage of hours you normally work, total number of hours. So again, in usual care, the first 2 bars, they start losing about 15% productivity due to absences, and about the end, they're losing about 13%. So there's, again, a little bit of a decline, which is, some of that may be usual care and some of that is regression to the mean, which is going to happen in both groups. But what we see here is that productivity loss due to absences, again, is cut in half in the Be Well at Work group. So again, a much better and important outcome. And here's, also the depression symptom severity. Some of you will be familiar with the PHQ-9, which is a highly validated questionnaire that's used all the time for depressive disorders. And again, you see people starting out about 14 in both groups. It goes down to about 10.5. Again, it's statistically significant improvement, but nowhere near as good as the improvement that we saw in the Be Well at Work program. So people come into the study 14.5, that's moderate depression severity. And when they are at the end of the study, in the Be Well at Work group, that's closer to mild depression. It's still not completely gone on average, but it's a lot better. So that's very gratifying. And obviously, the question here is that how long do people really sustain these effects over time? And we have a grant going with the VA right now in Philadelphia, the VA Medical Center, and we will be looking more long-term and doing booster sessions for people. So that's a really important issue for us to resolve. So just to give you another sort of slice of the depression issue. So here's the change in major depression. So employment status, let me just start there. Employment status, most people were employed at the end. Very few left the labor market, very few retired. So, most of the people were hanging in there, which is, really great news. We've done other studies where a lot of people turned over and left the labor market and so on, but this particular population, we had very little exit. But when we look at their depression scores, we see a much better response of depression to the Be Well at Work program than we saw to usual care. And what's really gratifying is sort of that percentage that went into clinical remission. And we see 37% in Be Well at Work versus 10%. And more people getting worse over time in usual care than in Be Well at Work. Small numbers there, but all important information for us that we hope can be sustained over the long term. Of course, we have to do our ROI, and everybody wants to know, is it worth it? And it's a pretty low-cost program, especially relative to medical care. Maybe not relative to standard EAP care, but when we look at sort of the annualized savings in absenteeism and presenteeism, it comes to about $5,103 per participant. It comes to about, that's what it comes to the estimate. And so if we want to say, assume people with an average salary in this sample was $63,000 per year, US dollars, with a 10,000 person company, we would estimate, the potential productivity savings of about $1.5 million per year. If we were using the U.S. median salary of about, which is almost $34,000 per year, it's right under $1 million per year. So could be very substantial savings to employers, and sort of depends on how the depression is distributed and how effective the program is outside of a randomized trial context. I think I'm missing a last slide there. Okay, so it's interesting. There's a couple of slides that are not, there we go. Sorry. Okay. So next steps for the Be Well at Work program, I mentioned we are currently testing it in the Philadelphia VA. Many of the veterans we're working with have PTSD, some have traumatic brain injury, many of them have other medical problems, all of them are employed. So having major problems functioning at work, much sicker than some of the populations we've seen in other studies. We are currently implementing the program, not as a study, but as a service within state of Tennessee government for government employees. And the goal there is not only to reduce presenteeism and absenteeism, but to try to lower the medical expense. So we're enrolling people that have extremely high, well, not extremely high, moderately to high medical expenses. Many of those people have undiagnosed or inappropriately treated depression. And so we're looking at whether or not by providing the Be Well at Work program and giving them good treatment for their depression and helping them at work, that we can also have an effect on their use of the medical care system for some of their other health problems. And finally, we've developed a Be Well at Work program for psychological stress that we are testing. So the takeaways today are that we know very clearly that depression has an adverse impact on functional performance at work. It's shown in elevated absenteeism, presenteeism, and lost productivity. And what I would just call what I see as sort of the misery index. The quality of life of people with depression in the workplace is poor. And they are, in many cases, very interested in finding help, and the help just hasn't been there. We know that functional improvement is not addressed directly in the biomedical approach to depression care. The model in biomedical approaches get people on treatment that improves their symptoms, eventually we'll see functional recovery. That's true in some cases not. So the Be Well at Work integrates a functional improvement approach, which addresses the multiple dimensions of barriers to functioning with other kinds of care. And we find that it is superior for restoring ability to work, and it is cost-saving. So I want to say thank you very much, and if we have time for questions and discussion, and if we run out of time, you should feel free to contact me at one of these email addresses or by phone. Thank you very much.
Fantastic. Thank you very much, Deborah. That was a really great presentation. Very, very, very interesting findings. And I'm really glad to see that there's such good successes with it, too. Let's see. So there was one question related to one of your earlier slides around the costs per employee that you mentioned even earlier than that. It was the ones for how much back pain costs, how much depression
the
costs.
pie chart.
Yes.
Yep.
And someone was wondering, are these costs per employee?
Yes, so the 109, for example, for depression is the productivity loss at work. It's not absences, it's just presenteeism for all employees. So if you were in any company, that would be the average cost per employee, healthy and sick. So not only the ones with that problem, but the ones without that problem. So, you know, we sort of look at the aggregate cost and then spread it across every employee.
Okay.
It's twice, you know, roughly a little more than twice as high as low back pain. Now, you know, again, you can get a slightly different picture on cost and proportion depending on, you know, which population you're using, which companies, but generally speaking, I can tell you from looking at data from hundreds and hundreds of companies, both in the U.S. and Canada, that depression is always in the top 5 of the presenteeism costs per employee.
All right. And then someone was wondering, anxiety disorder is found frequently with depression. Does Be Well at Work deal with that at all?
So that's a great question, and we have not developed a program specifically for anxiety, but that is correct that many of the people who do come in the program will also have undiagnosed anxiety. Some of them will be in anxiety medications like Xanax, for example, and so they do benefit from the program. We have a book chapter coming out in Sir Carey Cooper and James Quick's next book on work stress, in which we took this study, the last study that I presented on, and we looked at people who had comorbid depression and moderate to severe work stress, which is as, you know, sort of close as we come to some anxiety symptoms because the symptoms look very similar. And what we find is the program is extremely effective for them as well.
All right, very good. And then someone was asking if the program is available in Canada.
Can be. Yes, we haven't implemented it in Canada yet. We would love to implement it in Canada.
Wonderful. And then is the Be Well at Work program, you mentioned that oftentimes like some of your totals towards the end were for like 10,000 or more, but is it applicable for mid-market employers like 5,000 or less?
Yes, you know, see, one of the things about the program is that it can be applied really in any setting, and so you know, we have an idea of, you know, sort of how many counselor hours you need per person, you know, in the program, and what it takes to sort of get people engaged in the program and so on. So yeah, it can really go with any size program. It really could work with small businesses banding together too. It, you know, could be provided through an EAP, so one of the things, or an insurer. And so one of the things that we do periodically is we will work with the EAP that might be providing services to a company, and they may be providing services to multiple companies. So that way some of the smaller companies can take advantage of some of the programs that they ordinarily may not be able to afford on their own.
Very interesting. Someone was wondering, have you been able to estimate the amount of one-on-one care time you spend customizing skills for employees outside of the web-based interaction?
What the counselors do, is that the question you think?
I think so, yes.
You know, they spend roughly, you know, no more than a half hour. It's usually like 15 minutes per employee per session for documentation and sort of prep. But, you know, some will spend longer than that, but it's an average of 15 minutes. So when we do the RRI, we actually have to cost all these things out. But we have a weekly supervision that all counselors that are providing services are required to attend, and we do very detailed case discussions. And so we will pick cases and we will go through them and look at sort of what's being done and suggest different approaches to dealing with the work problems in particular. So two types of problems tend to come up in supervision. One of the types of problems has to do with the medications that people are taking. And so the counselors don't necessarily have that kind of training. So we have a senior psychiatrist, David Adler, who's working with the counselors all the time and helping them to communicate with the providers and with the employees around some of these medication issues. So we don't expect counselors to know all about those. And, you know, for example, in Tennessee, we have people that are on, you know, 8, 10 medications. And so these are really complicated issues that have to be sorted out. And the other type of problem that we see very often has to do with really customizing to the work situation, and that's where the counselors need the most support in. And so really thinking about, you know, what is happening on this person's job, where are they really running into trouble, where do they have some opportunity to modify how they do things, where they do things, with whom they do things, without necessarily drawing attention to themselves. Because one of the things we're really careful about is we don't require people to tell managers or tell coworkers that they're in this program. In fact, we go the other direction, which is to be private and not to go into the workplace. So we want to give people suggestions that are, you know, more or less invisible to other people, that fit within the context of the job, that aren't going to stress people out and make things worse. And so we're very, very careful about that. And so we do things, you know, start on a small scale and may, you know, try different things and then add different things to the homework assignments till people have sort of a menu of options that they find to be helpful. And one point that I didn't make is at the last session or close to the last session, the counselor and the employee develop a self-care plan together. And so they look at what were the problems they came in with, what were the solutions that seemed to be effective for them, and they get a document that sort of reminds them of, you know, sort of what worked, what didn't work, and how to use it.
Wonderful. And then one last question. When screening participants for the study, were they screened using the WLQ or another?
They were screened with the WLQ, the PHQ-9, and depending on the particular project that we're doing, there might be some more things in there. So the state of Tennessee is also screened on utilization and insurance status, but it really varies. But the WLQ is always in there. The absence questions are typically in there in the screener. So presenteeism, absenteeism. If there are exclusionary criteria, some companies want certain things excluded or other things included. We will do that. So, for example, we might do a program that includes minor depression, which, you know, in the data that I showed you wasn't in there, but, you know, we can adapt this program for minor depression too, which is a large number of people. So, you know, it depends. Kind of the instrument is designed to be really short and done online very quickly and give immediate feedback. So, you know, we don't want to burden people too much. We do ask them after they qualify for the program to do a pre-intervention baseline and a post-intervention follow-up. So we always have data, and that data is typically are collected online as well. So the information system does the screening, and it also does the routine data collection as well as generating all those reports to providers and so on.
Great, thank you. Okay, we are right at time. I did get one question last minute, but I will pass that on to you, Debra, separately. It was just I'll pass that on because we do need to end so that we end on time. Thank you very much, Debra, for your presentation and for speaking with us today on this important topic.
And thank you all for listening in. I really appreciate it.